and very good evening. I am Dr. Sabia Nazmeen, Senior Consultant of Gynae Department, Rangpur Medical College Hospital. Welcome you all in weekly virtual session on gynecological malignancy journal representation. Now I am going to present my case.
Next.
Mrs. Hicks, 55 years old, regularly menstruating women, mother of several children, all were home delivery, and 4 children were alive. Had no history of contraception. She was non-diabetic, normotensive, presenting with irregular pervaginal bleeding for 3 years. She also complained of occasional postcoital bleeding for 2 years. With this complaint, she consulted with different physicians and every time she was treated with oral progesterone. Her symptoms was revealed with drugs, but she was on irregular drug. And now query here, is it the age of her menopause or not?
As it is, she's Samir আগেরটাই থাকুক. As she is 55 years,
Yes,
still
ma'am.
is menstruating. আপনি একটু
Yes,
আপনি
she is 55 years and is still
55
menstruating woman.
still she is menstruating. And should we think this is for menopause?
Yes, in our
জয়দীপ স্যার,
perspective,
আপনি ওনারা উত্তর দেবেন, আপনি কিছু বলুন।
Tumor board.
স্যার প্লিজ, স্যার প্লিজ, জয়দীপ স্যার প্লিজ, আর ইউ হিয়ার?
Yes, yes. Yes, some women will have a delayed menopause, but of course, average age of menopause around this part of the world is 46, 47 years. So 55 years is an age when we expect a woman to be in the postmenopausal age. But some women can continue to bleed even for a longer period of time.
Next.
next question. Is progesterone justified without evaluation of genital tract?
Never. One answer, never.
Yes. Next.
Yes, sir. How will you evaluate a patient with irregular vaginal bleeding in this age?
So first of all, she needs a thorough history taking, whether the irregular bleeding is because of the medicine she is taking, the post-coital bleeding, whether it's fresh bleeding every time, more details about the history. Then she needs a thorough clinical examination that includes a perspective examination of the cervix. And then depending on what we find on the examination, appropriate investigation should be arranged.
Next.
Thank you, sir. For last 2 months, her bleeding was excessive in amount. She developed severe anemia and received 4 units of blood. Then she was referred to National Institute of Cancer Research Hospital. On examination, she was anemic, all accessible lymph nodes were not palpable, examination was normal. Regarding her pelvic examination, cervix was broad, barrel-shaped, and there was a cervical ectopion, an ulcerated growth around 5 to 6 centimeters in posterior lip of the cervix. Regarding bimanual examination, uterus bulky, all fornices were free. Rectovaginally, both parametrium were free. Biopsy was taken from this growth and sent for histopathological examination. Here is the picture shown the growth of the cervix arising from posterior lip. Her histopathological report shows adenocarcinoma grade 2 variety.
Next.
Ultrasonogram shows uterus was 10.3 into 6.3 into 6.4 centimeter in size, endometrial thickness 28 millimeter, cervix inhomogeneous, hypoequic area seen, measuring about 4.5 into 3.4 centimeter. Now some query. Endometrial thickness was 28 millimeter. Should we need for endometrial evaluation?
AK, please, AK. AK.
जी madam.
AK.
Shall I continue to answer?
Joydeep can answer in that case.
Yes, yes, sir. Yes, sir. Sir.
Joydeep.
Sir.
Okay, so yes, the histopathology was an adenocarcinoma.
Yes, sir.
And in view of endometrial thickness of 28 millimeter on ultrasound scan, it is essential that we evaluate the endometrium as well, either by, if possible, ideally should be a hysteroscopic examination of the uterus and a biopsy from inside the uterus, because adenocarcinoma can be originating from the uterus as well as from the cervix. So it's very important that we evaluate the endometrium in this particular woman.
Yes, sir. Okay. Next.
Next. If adenocarcinoma is also found in endometrium, how can we sure about the primary site of origin?
There are two ways. First of all, you do an MRI scan to see where the epicenter of a disease is, but most surely it should be the immunohistochemistry of the tissue sample,
Yes.
and we're looking for markers like WT1, PAX8, and looking for markers like P53, P16. So the pathologist would be the best person to answer whether it's originating from the cervix or from the endometrium, and that is very crucial in the treatment of this woman.
Next.
Ultrasonogram show no hydroureter necrosis. Should we go for IVU, intravenous urography, sir?
No, it's hardly ever done nowadays. IVU is not routinely done for evaluation of gynecological cancer patients in modern practice.
Next.
Thank you, sir. This is the MRI report. Next slide.
Can I go back to the previous slide, please?
Yes, yes, sir.
Yes, sir.
Okay, fine. Go on.
Next slide. Next. Here's some focus. Hyperintense cervical lesion. 3.2 into 6 centimeter is noticed, which distorted the hypointense cervical stromal ring and hyperintense epithelium on its lateral aspects of the cervix, and the ragged tumor protrude through the defect beyond the ring into the parametrium. Ill-defined extent extending from tumor to left broad ligament is noticed. This is MRI report. So now query. What is our diagnosis now, sir?
So they haven't mentioned anything, because I could see some lesion in the endometrium as well. They haven't mentioned about the endometrial lesion on the report.
Next.
Sir, no comment regarding the endometrial growth in the MRI report.
There was no comment. Okay.
No, no, sir.
Yes, looking at actually
Yeah,
the MRI.
I will
Yeah.
not put my money on that, because there was I could see a lesion in the endometrium. It could be a completely benign endometrial polyp, just an incidental diagnosis. But because you have an adenocarcinoma, which is an uncommon diagnosis in the cervix, it is essential that we undertake immunohistochemistry to confirm whether it's originated from the cervix or the endometrium. So if it's a cervix, then obviously there is parametrial involvement, and you will not dare to do any surgery. But if it's endometrial origin, then of course there's a role of surgery in the treatment of this patient.
Next. What further investigation should we do now, sir?
So immunohistochemistry of the biopsy specimen.
Yes, sir.
Next. Endometrial curettage.
Can we go
So
for
I-
the endometrial curettage, sir?
I would prefer endometrial a hysteroscopy, because you can actually see what is happening in the endometrium rather than looking at the shadow of it. And if there is a polyp or something, you can actually excise the polyp through the hysteroscope. Endometrial curettage can occasionally miss an appropriate lesion. So preferably a hysteroscopy and a biopsy.
Sir, where
Especially when the
hysteroscopy
diagnosis-
is not available, in that cases, can we not go for this endometrial curettage? Hysteroscopy
Of course,
not
if,
available.
if it is not available, you go
Yes.
for a very thorough fractional curettage,
Yes.
something we did before. Yes, of course you can.
Endometrial curettage was done and histopathological report was adenocarcinoma grade 2. Next slide.
Next.
And what should be the next?
So I'm coming back to the same proposal. You have to do immunohistochemistry. Adenocarcinoma is a very broad diagnosis. You need to know whether what type, what subtype it is, whether it's mucinous, intestinal type, GI type, whether it is serous, endometrioid. So there are so many different varieties of adenocarcinoma. If it's from the uterus, I mean, of course, the most common type is endometrioid. From the cervix, you get mucinous variety. So that's the pathologist to answer.
Next.
Immunohistochemistry not available in Rangpur Medical College. Now what will be the treatment plan, sir?
See, for the treatment, the immunohistochemistry is extremely important. The reason is because if he is diagnosed to be a patient of cervical cancer, I'm not going to venture into surgery for her.
Okay, sir, thank you.
Background disturbance coming. Yeah. Okay. So
Mute others. Amit, mute others.
Sir, I have given you the co-host thing, sir. You can mute others, sir.
Next slide.
Dr. Bhaumik, can I just add, Supriya here?
Yes.
yes,
Yes.
yeah, go on.
I will put my money on this being endometrial cancer rather than cervix cancer, because
Very good, yes, absolutely.
MRI doesn't look normal,
No,
and
I agree with
the
you. I agree with you.
extension is at the level of broad ligament.
Hello.
Although
Into
they have
the
reported as a cervical primary, but I could see a
Yeah.
lesion on the, if you look at the image very carefully,
yes,
is a definite lesion in the endometrium, and possibly that is extending into the endocervical canal.
আপনি mute হন আপনার
Yes.
শব্দ আসছে।
and extension at the level of broad ligament
Yeah.
for a cervix primary will be relatively
Very, very
rare. So
Absolutely.
yeah.
So,
Hi, can I add some things? Is
Yes.
that okay? Sorry. So you have an advanced adenocarcinoma. You think it's from the endometrium, and to the points made, the issue really is it operable, or do you need to do some sort of neoadjuvant chemotherapy or radiation or both first? And if you were calling this a cervical cancer, you standardly do a weekly cisplatin with radiation as your first thought. If this was an endometrial cancer, you could still do that. The other thought would be you could do carboplatin Taxol as sort of some neoadjuvant chemo. So really, you've done a beautiful, beautiful workup. And one of the things to think about is there any distant disease? I wasn't sure if I missed that. I've been just coming out of surgery, so I'm not sure if I missed some of those details. But what did you know, how are her lungs? How's her liver? How's periaortic nodes? Do you have other information that would be helpful as you're planning this out?
Yeah,
so
because-
where immunohistochemistry is not available, so what will you do in this patient?
I mean, if it's not available in Rangpur,
Yes.
I'm sure it can be sent to Dhaka.
This is all time patient cannot come, sir.
No, no.
The patient then,
I'm thinking for the idle mind, as
Yes.
Dr. Goodman said, that the treatments are completely different.
yes,
Treatments can be different because the modality of treatment for a cervical cancer will be primarily a chemoradiation. But here, as this case suggests, as Supriya also mentioned, that from the image point of view, from how it presented, her age and everything, it's a good possibility that it's endometrial cancer. And if that's the case, and if there's no distant metastasis, then of course the treatment will be surgery. So there is a difference in approach. So I think patient should be counseled appropriately that we would like to give you the best treatment. And to get the best treatment is preferably, you can wait a few weeks or maybe a week or so before you get the immunohistochemistry result, because that will go a long way to actually identify the origin of disease and tailor the treatment accordingly.
Sir, could you add HPV testing? Would that kind of sway you in terms of it being an adenocarcinoma cervical versus endometrial?
Of course, that can help to identify the cervical primary. Yeah. But there should be a battery of immunohistochemistries to identify. Yeah.
So, but Dr. Jaideep, I think Shahana was trying to address in a sub situation, say, if there is no opportunity to do some IHC, so say we create a scenario. So how, in that situation, how to proceed?
If I'm going by the image only, then I would prefer to think it is an endometrial cancer and give her the option of surgery. It will not be an easy surgery. Of course, it should be done by a properly trained gynecological oncologist because there is possibility that the broad ligament is involved or infiltrated. The ureters will be at risk. So it should be done by a properly trained cancer surgeon, not just a simple THBS of her.
Radical hysterectomy.
Not just radical, because there is a possibility of involvement of the broad ligament. So the ureter is at stake. So it will have to be done by a person who is trained to tackle the ureter in these areas.
Why not radical? Cervix is involved, sir.
For endometrial cancer, radical hysterectomy is not really indicated unless the parametrium is obviously involved, because if the cervical stroma is involved, all these women will actually need post-operative radiotherapy.
Yes.
So radical hysterectomy is not still some people will do it, but it's not the preferred method of treatment, and it's not necessary, unless, of course, if you see on the MRI there is obvious parametrial involvement, you need to have a clear margin of the tumor, then we do a radical hysterectomy. But if the parametrium is not involved, if the tumor is confined to the cervix only, a simple, I would not say a simple, it's a difficult hysterectomy anyway, but you don't need to take the entire parametrium out. Like for
Dr. Supriya, please.
I will also like to have opinion of AK, but if I were in multidisciplinary clinic, I will really nudge the surgeon to operate this case, because I am also convinced that this is higher chance of it being an endometrial cancer. But I just want to listen to other opinions also.
Dr. Bhavnant, is it radical hysterectomy or simple hysterectomy? Dr. Bhavna, please.
Again, like Dr. Bhaumik said, radical hysterectomy is not done in many institutes for endometrial cancer now. But Dr. Supriya and Dr. Bhaumik, just discussing the other option, will be an option of upfront radiation in this patient and then assessment for surgery?
If it is endometrial cancer?
Yes, there are also opportunity, but that's why Bhavna brought the issue. Supriya, what is your comment?
Yeah.
In some situation, we can go for that.
Yes.
As a surgeon, I would really hope to operate on somebody who has received a complete pelvic radiation. It's especially somebody who I'm suspecting that the ureter was involved, and then she's receiving radiation, and then I'm trying to do surgery. It is not an easy job.
Yes, because the reason for my saying this is that not every center is going to be, having that kind of a surgical backup.
Yes, of course, yes. If you do, that's why I say the surgery is not easy surgery. It should not be attempted by somebody who's not trained in cancer surgery. It should be done by a cancer surgeon who knows the every millimeter of the pelvis. And of course, if that is not available, then primary chemoradiation is a suitable option, of course, yes.
So just to make it a little spicier, actually in the United States, we do radical hysterectomies for stage 2 endometrial cancers. I don't think there's any particular rules around it. I totally resonate with your point about if you know that you're going to add postoperative radiation therapy, do you have increased morbidity with doing a radical case? Ultimately, what I think is, from a surgical point of view, your tumor informs your surgery. So you follow the tumor. And looking at this MRI, which is a beautiful MRI, you can really see this tumor. Whatever the primary, and it may indeed be endometrial, the bulk and the burden of disease is in the cervix. So if we think about where is this tumor going to spread to, it's clearly being spread in a local way. And so it has a risk of spreading to the vagina and to the parametria. So that needs to be managed in some manner. Definitely after radiation, surgery can be much trickier. You're absolutely right. But anyway, I just wanted to say that I think there's no one particular rule about radical versus simple surgery in an locally advanced endometrial cancer. You might do it based on your own clinical judgment, your examination, opening the spaces, and so forth. My personal tendency when I look at this MRI, assuming she has no disease anyplace else in her abdomen, would be actually to do an old-fashioned laparotomy, radical hysterectomy, bilateral pelvic node dissection, for sure. And you'll have much more histology from that to decide about other therapy. On the other hand, if this is not operable, okay, and that's really what you need to sort out. If you have immunohistochemistry, that's awesome. If you don't, really your decision tree is about, is this operable or is this not operable? And if it's not operable, then you have to make a determination. Are you going to do chemotherapy? Are you going to do chemoradiation and so forth? So yeah. I'm gonna actually look up NCCN guidelines while we're talking to see if there's any word about the type of surgery based on advanced endometrial. So I'll let you know. I'm gonna look it up right now.
But just to add, so being a radiation oncologist, it's not easy for me to say surgery, but I'm still saying surgery first, because I think in this patient, I think good surgical staging is important, because if it turns out to be stage 3 endometrial cancer, which it looks like, you are also taking away from patient the chance to receive systemic chemotherapy, which we know is associated with some kind of survival benefit. So the two case scenarios are, one is you think it has cervix cancer, give chemoradiotherapy. There is a reasonable chance, 10 to 15%, that she will have residual tumor at the end of treatment at 5 or 6 months. And then you end up doing either salvage chemo or salvage hysterectomy, depending on how the outcomes are. But the other thing is that you do upfront surgery. I think I would put my money on endometrial cancer, do a nodal staging. It turns out to be stage 3. You give systemic chemo and CRT. Chances of her overall outcomes being better, I think, are much higher than trying to jump in and do chemo radiation. At least that's my thought process.
Supriya, let me add with you. What Bhavna was trying to add into the discussion, not maybe for this case, because there is a common school of thought that, as Dr. Joydeep said, I totally agree that endometrium surgery is first, but in some special situation, there is an opportunity of chemoradiotherapy. Maybe not, this is not an ideal case for that we can end up with the chemoradiation also. So maybe for the student, there is a message that cervical cancer, yes, chemoradiotherapy; endometrial cancer, yes, surgery followed by radiotherapy, brachytherapy plus minus EBRT. But in some very special scenario where surgery is not suitable or not feasible, as Dr. Joydeep was repeatedly pointing that it should be done by a skilled surgeon, because we know it is better not to do a surgery than to do a half-hearted surgery. Because as you said, after chemoradiotherapy, 15% residual is one issue, but cut through tumor is much worse than that. So that is worse. So Joydeep was focusing on that issue very much, that before doing the surgery, there should be a good level of confidence that we are attempting is R0 resection. Knowing a R1 or R2 resection surgery should never be attempted, because where there is a you see there is involvement of the suspected involvement of the ureter. So I think Bhavna brought not focusing on this issue, but to maybe that discussion that in some situation where surgery is not possible, even it is a endometrial, there is some special situation we can try. We are not very happy to do chemoradiotherapy without surgery in endometrium, but that is an option.
Yes. Can we go for chemotherapy first, followed by surgery? Chemotherapy?
AK, neoadjuvant chemo followed by surgery. What's your comment on endometrium?
Endometrial cancer in this patient, for this patient.
It sounds to me, if I heard it correctly, again, I was in a noisy place, but that she was having heavy bleeding. Is that right?
Yes.
Yeah. So
yes.
So I would probably do radiation first, because you're going to control the bleeding, right? And you could see from that picture and also from the MRI that she's got a big problem in her cervix. So yeah, personally, if possible, I would probably start with radiation. I appreciate the point that was made about sometimes you're going to alter your histopathology and you'll never end up knowing what this was. But on the other hand, we're clinicians ultimately, and this lady is bleeding. She's got a big problem. And the best way to control this is with good, righteous radiation, chemoradiation. That will control that, and then you can make a decision about, chemotherapy later. Probably if you do radiation and there's no sign of distant disease, my next step would be surgery. So I actually just found, and I didn't find anything in NCCN guidelines. They stay away from the controversy about type of hysterectomy, but I did find a nice paper looking at the impact of radical hysterectomy on endometrial cancer with cervical involvement. Look at that, 2020. I will send an email to Shahana with it, and so she can circulate the paper, okay? Basically, the point of the paper was both techniques are fine. You don't really improve survival necessarily with the radical approach. And so it gets back to the issue of clinically, when you're there as a surgeon, how do you get around this tumor with good negative margins? And if that requires a radical hysterectomy, there you go. In their study, they said that the 5-year survival for simple hysterectomy followed by radiation was 76%, and the 5-year survival for the radical hysterectomy group was 89%. They said it wasn't statistically significant, but there is a difference in survival. So again, it's interesting data. I'll mail out the paper. Okay.
Okay, so I would just want to say that although I completely agree with Supriya and Dr. Joydeep, so that should be definitely considered as the first option. But the reason for bringing this up was not that it is an alternative, but it can be used as a second option if we do not have the facilities, or for some reason we cannot do a proper surgery.
That I think that's the most important word, is a proper surgery. Because if you cannot do, as Professor Kamal said, that if you cannot do a proper surgery, don't attempt it, because half-hearted attempt, mutilating the reserve or the tumor is not at all desirable. That will make the woman's life worse. So if you are able to do the surgery, do it. Otherwise, primary treatment, choose chemoradiation, assuming that there is no distant metastasis from this tumor.
I think Dr. Kamaluddin also asked one very important question about radical chemoradiation if it is an endometrial cancer. And I think annually in our institution and also for other institutions, we treat quite a few patients where because of medical comorbidities, they cannot be operated. So for the students, he wanted a message, but yes, you can do. Only thing is that brachytherapy is slightly different for such patients because you would like to cover the uterus better. So there is a bit of change in brachytherapy, but yes, that is very doable. But for us, at least in Asia, I don't know about Bhavna, how it's in Chandigarh. Maybe we can hear from Dr. AK. We don't have large series here of patients who've been treated with chemo radiation for endometrial cancer radical. How are their outcomes?
I agree with Supriya. We have also had cases where we have treated patients, but then they are very few. So, I mean, it's difficult to ascertain. definitely. So I think probably we can just pull some data and then see the
So,
outcome.
Supriya, let me share with you. I was fortunate to be in McGill Women Hospital with Dr. Sushil very well. And he is fan of doing all these fancy brackies, and at this day, even 2010 I saw him, and I found him that he has a good series of doing radical treatment, as you said, that whole brachytherapy covering the whole uterus. As you said, I have seen the cases doing there, and he has a good series of that. As we know that the number of endometrial cancer is also quite high in those areas, and they are having a very old-fashioned patient where they cannot, for the comorbid, they cannot do the surgery, and they are doing it. So, as you said, it is not a classical recommendation, but the students should know that there is an option which is not very popular or frequently used, but in some scenario, they should not think that it is not possible. It is possible. That was the message. Thank you.
Yeah. And just to add, the brachytherapy applicators are very different for these kind of brachy. And we don't, most of the centers don't invest in it because these scenarios are not very common. So many times when I'm doing brachy for these patients, I have to use a brachytherapy applicator because the brachy is very
Yeah. And for this,
surgery.
surgery, yeah,
Surgery.
surgery, and
Surgery.
like this, as this patient, she is from the Rangpur Medical College, which is around 250 to 300 kilo away from like this peripheral area, where good surgeons or half-hearted, as you stated that half-hearted surgery is bad for everything, even endometrial carcinoma, carcinoma cervix. Sometimes we have seen that carcinoma cervix, extended hysterectomy like this type of, and it is a, what is your message if this type of surgery is tried there? What is your message? Then what may happen to the patient?
Already Joydeep told it. Joydeep can repeat.
Yes, sir, please give a message to all of us.
So I have seen women having subtotal hysterectomy for cervical cancer.
Yes, sir. As on
So
many patients are
patients
going
have been
through.
taken to the operating theater telling that a
Yes,
hysterectomy will be done.
yes,
And just to save the skin, the doctor has a subtotal hysterectomy, but because couldn't remove the cervix and tumor was in the cervix. And these are the worst cases. These are the worst cases when they come to us. Giving radiotherapy is, Shukriya will agree with me, and Professor Kamaluddin also, that giving radiation to them is not only difficult because it's only as part of the cervix is there. Um, the ball gets stuck to the top of that cervical stump and the scarred area, and the morbidity is extremely high. Just remember one of my recently I had to help one of our radiation oncologists just to put the tandem in, because after surgery it was so scarred, so weirdly placed. We had to use a hysteros to find the actual cervix just for them to put the tandem in. So it is very difficult even for the radiation oncologist even after incomplete surgery. So please do not attempt incomplete surgery. If you are confident you can do it, if you have been trained to, it's not the confidence. If you have the training to undertake radical surgery, then you do it. Otherwise, please refer to the patient. Please refer to the patient. Traveling a little distance will actually add years to her life.
I have slightly different opinion, if I may say. So
Sure.
one thing is that you're right, such surgeries are not should not be attempted, but it is also a reality that such patients we see very often. We cannot control what happens in the community. So in our institution, I think there is rarely a situation where we are not able to do external radiation and interstitial brachy for these patients. And we have back to back published our outcomes of these patients where we have done chemoradiation and interstitial brachy, the latest being in this year's Red Journal. So we are at 86% local control rates for these patients. Obviously, it's not an ideal situation. So I'm trying to describe that actually you end up having such a patient, then what you should do. So I think doing aggressive EBRT followed by interstitial brachy is very good for these patients. And our outcomes that we get with interstitial brachy are almost the best in the world. So if you actually end up with such a situation, I think doing CTRT and cylinder only brachy or a simple brachy doesn't lead to same results. So you have to cover what a surgeon would have otherwise treated, at least with a type 2 hysterectomy. So interstitial has to be done. Why? Because if you only use a tandem, because it's a small stump, you still cannot prescribe to point A safely. So that is the message in case you land up in such a scenario. Of course, it's not ideal.
Supriya, the problem in our country is that we are very much popular with ICRT and vaginal cylinder. I mean, the issue of this, what you said, this is, first of all, it needs skill, it needs practice. So we are not routinely practicing this thing, number one. Number two, we love to see the data of TMH, but that should not be, prompt us, because, in TMH, you are fortunate to have a full team that most of all are performing near equal skill, with near equal skill. But in our country, the skill is totally different. Say, even doing ICRT, we are not sometimes very much sure about the outcome. So yes, this is a good message from you that it is doable. But from my end, the message is, in our country context, we should be very cautious of thinking of this solution unless we are very confident that we know what we are doing. Because just listening to the 86% data of TMH, and we should not jump in, because we should know. Because what I was trying to say, and Dr. Jaydeep was telling, that I should know what I'm going to do. Because looking at somebody else doing a wonderful surgery, or looking at Supriya that she is doing a good brachytherapy and interstitial and getting 86% survival, it is very good to see and get encouraged. But I should be trained. I should be skilled enough to attempt for that. Otherwise, I will end up with doing only a vaginal cylinder, and I will regret that, well, it was not a good thing.
So in that case, again, a middle path could be doing an intracavity if an interstitial is not possible at your center. But as far as possible, an intracavity should be attempted after seeing the vagina, the stump length. So that can be easily measured with the help of an MRI. So I think as far as possible, a brachytherapy should be attempted even if there's a subtotal hysterectomy.
So we can take the message here that if there is an inadequate surgery, the radiation oncologists need to assess what is the residual area, and then they need to apply all their resources to cover that up by EBRT, chemoradiotherapy, and by interstitial ICT, whatever weapon they have, because they don't have two chances. They need to do it in one go. And as Supriya said, they had a wonderful series, because with interstitial, it is possible to cover all the area which would have been covered by the surgeon. So they can assess where is the area, they put the needle there and they put the radiation there. So that is the secret of the high success of interstitial. So what Bhavna and Supriya is trying to give us the message to the student, that if we end up, it is not an ideal scenario, we never appreciate it, but if there is a situation like that, we need to try to address as much as possible by radiation, that is in the form of EBRT and mixed with ICRT or interstitial brachy, to address the area, because we don't have, as we said, there is no second chance. Thank you.
So, what is the last comment of this patient? If this patient is treated in, as it is a case of Rangpur Medical College, so they, at first they should go for the chemoradiation and then we'll try for surgery. The last message, what is the last message?
There is no clear message from all of us.
No.
I think if it is in Rangpur,
yes,
the surgeon thinks for the sake of the patient, Dr. Jaydeep was telling, we can wait for 7 days, or we can allow the patient to travel few hundred kilometers to come to a center where either there is a possibility of a good surgery or good radiation. Because I am not against Rangpur or against any center. I am in favor of getting the best treatment.
No,
so
Amal Bhai, as you know, maximum of our patients, they are treated as some patients, even they cannot, they have no money to take that, to buy their drugs. So how can they come to from periphery to center? In that area, how this patient should be treated? For those patients.
I have a suggestion here. which
Yes.
is very close to my heart. I mean,
Yes.
I've been involved with instituting training in obstetrics, in gynecological oncology. I think as a long-term plan,
Yes.
these peripheral medical colleges should be aiming at getting at least one, not more, oncologist and gynecologist trained in proper. It takes a couple of years for training, but it's extremely important that the people living in that area get access to proper treatment. It's only the training. It's not that I cannot do it. It's only a matter of getting proper training and practice in your own area. That gives the best result for the people of that area. So gynecological oncology is a super specialty where people should be getting training, appropriate training, and then of course the service can be rendered to the community. This is something very close to my heart. I strongly believe in that. It's a long-term investment that the government and the institution should do.
So we will have.
Can I say a few words regarding our situation, Professor Shahana?
Yes, yes.
Good evening, everyone, and welcome to Bangladesh webinar. So this is a scenario of Rangpur Medical College is like this. Professor Shahana has told it is far away from Dhaka. But I would like to say that though it's far away from Dhaka, but there are some senior gynecologists of us who can do Verdim hysterectomy. Professor Joydeep sir has told that sometimes he gets like subtotal hysterectomy, but we don't practice subtotal hysterectomy.
Fantastic.
Some clinical cases we can do because we are trained in oncology, so that we can do Verdim hysterectomy easily. And in some situations, when we feel necessity to take the help of the urologist to tackle the ureter, we can take, because there is multidisciplinary team. But the scenario is like this, sir. Some of the patients, as already told by Professor Shahana, most of the patients have no money, they want to go. When we think that we will not be able to tackle the case, then we refer the patient to higher center, especially Dhaka at Shahana Center or BSMMO. But the patients are so unable, but they don't want to go. In that case, we take the help of chemoradiation at first. This is the scenario. Thank you, sir.
Okay, thank you, Appa. Is it dual malignancy, sir? Is it maybe dual malignancy? Cervix and endometrium?
Dr. Joydeep.
Sir has some network issues.
It's very rare to have a dual malignancy of cervix, and normally it's either the cervix extending to the uterus or the dual primary with uterus and ovary is possible. Dual primary cervix and endometrium is extremely rare. It's generally either cervix climbs up to the uterus or the uterus descends down to the cervix. That's more common.
I completely agree. And I'm just going to make one more comment. I'm sorry, I have to leave for another meeting at 11. I'm sorry, 11 Boston time. But we were noticing in the United States now, because of our great tragedy of COVID, that we have a delay in diagnosis in cancer. And I'm seeing it here in Boston, extraordinarily increased delay in diagnosis for many cancers. And I've seen many women now with endometrial cancer. There's been a delay in diagnosis, and they're coming in like this with this very advanced looking disease. That's all endometrial cancer. It's very sad. I know in Bangladesh, so many people are poor. You don't have sort of a national healthcare insurance system yet. And as a result, people pay out of pocket for their healthcare. And so we see in Bangladesh routinely people who come in with delay in diagnosis, as this woman did. So that's my comment. It's very sad. Now in the United States, we're seeing this because of the tragedy of COVID, where the hospital systems are being overwhelmed by the infection. So for the future, whenever you can get it early, my right hand's okay, honey. You know, so just for a public health service announcement, these young women with bleeding need to come in right away, you know, that needs to be part of our job as oncologists. Okay, I look forward to seeing you next week, I hope. And thank you so much for the opportunity. Bye-bye now. Yeah.
Thank you very much. Next. So every question is complete. Next. Okay. Can you go for the second case?
Yes, please go for the second case. But before that, during that time, I want to respond to Dr. Shahi Farzana that, Madam, we completely agree with you. But why we are taking this initiative that you are the focus of your region. But you know, in near to you, within 100 kilometers area, many things are happening. And you are the sad witness of those cases. So this is not Rangpur Medical College. We are trying to bring up the whole scenario of the total zone. So when it is required, they should send to you. When it is required, you send to center. That is what you are practicing. But it is not for the medical college. We want to send the message to the remote area of our country so that not a single lady in a corner of the country is suffering. We understand that in Rangpur Medical College, it is not going to happen. But you know, any part of Bangladesh or India in Calcutta, it can happen. So we want to prevent that. So we appreciate the leadership of all our medical colleges, including Rangpur, that you are doing it, and you are representing area. And when we are representing, we want to be very honest that we everywhere it is not same. We have some focus area where we have some weakness and we need to cover it up. So we salute you because what you are doing in Rangpur is a big challenge because it is far away from Dhaka with much limited resources, and you are doing a great job. And we salute, but we want that we bring up everybody, not on the medical college, but all to the peripheral area. Thank you, ma'am.
Not only
Thank you.
another message is
Congratulations
that
to the club for your great initiative. Thank you so much.
patient should have single treatment. Sometimes we do dual modality of the treatment. They should give the single treatment, either surgery, then follow up, or the either chemo radiation, then follow. That should be our aim.
That is very appropriate for cervical cancer, but
Yes.
most of advanced endometrial cancer will need 2 or 3 treatments. That is a reality. But for cervical cancer, yes, you're absolutely right. If
Yes,
it's cervical cancer,
yes.
we avoid dual treatment. Yeah.
What I think that this COVID has given me a big opportunity, Dr. Jaideep, that
Yes.
before it was none of us were very much available. But this COVID, one good thing of COVID is it brought the world together. So I think, say, Dr. That I know the initiative of Dr. Shai team, that in some situation, she will not reach us. Maybe she will be reaching you even when required by the, by this remote area and remote technique. And this is how I think the world will become small and we will enjoy the technology and we can serve better. So we will have a global tumor board very frequently because we have initiated the opportunity and it is very doable. I think even Rangpur can try to, if they have some cases, they can notify somebody at your center, take some opinion. It is doable. COVID taught us that we don't need to kill ourselves to take the solution. Thank you.
Exactly.
Thank you, Dr. Kamal Bhai.
Yeah, just a little point
Yes.
that while we are talking about the surgical expertise, I think it is also important to have a very good pathology backup. So IHC, that is of prime importance because half the problem is solved if we have the facilities for good pathology and an immunohistochemistry.
Yes, yes.
Shana, we move next case.
Yes, okay. Thank you, Dr. Sabiha, for your presentation. Now I request our second presenter. Second presenter is Dr. Mahbooba Khatun. Dr. Mahbooba Khatun is assistant professor from Rangpur Medical College and Hospital. Mahbooba, please.
I hope you all can hear me.
Yes.
Respected chairperson of today's session, Professor Kamrunaha Jui, head of the department, Gynae and Obs department of Rangpur Medical College, respected overseas guest faculty, all of my senior and junior colleagues, and Larden audience, Assalamu alaikum. With due respect to all the martyrs of independence war in this month of victory, I, Dr. Mahbooba Khatun, welcoming you all to this case presentation. My patient, Rabia Begum, 50 years old, regularly menstruating woman, mother of 3 children, had irregular pervaginal bleeding, which was moderate in amount and intermittent in nature for 8 to 9 months and associated with generalized weakness for 3 to 4 months. On general examination, patients were severely anemic. Abdominal findings were normal. Vaginal examination, there was an exophytic lesion about 6 centimeter in diameter in anterior lip of cervix, extending to upper 1/5 of anterior vaginal wall. On bimanual examination, anterior fornix was shallow, other fornix were big. On recto-vaginal examination, both parametrium were free. Histopathological report was squamous cell carcinoma of cervix, grade 2. Clinical diagnosis was carcinoma cervix, stage 2, A2. Now the question arises whether examination under anesthesia is needed for cervical cancer staging.
So, Deep sir, please.
It is not essential nowadays to undertake examination on anesthetic for cervical cancer. I just saw an image of a good MRI in Rangpur. So if we can do an MRI for this woman, we will, I mean, the main intention is to assess, because the anterior wall of the vagina is involved. My interest will be to see if the bladder is involved or not. If the bladder is seen involved or suspected to be involved in the MRI image, then only there will be a role of an examination under anesthesia and putting a cystoscope to see if the bladder is involved. Otherwise, majority of the time, a good MRI scan is sufficient to do a local staging for cervical cancer.
Okay, thank you, sir. We should we go for cystoscopy for further evaluation of bladder?
As I said before, if we are able to do an MRI will guide me that whether cystoscopy is necessary or not. If I do not have the facility for a proper or good MRI scan, then of course cystoscopy will give us a very big, especially because the anterior vaginal wall is involved. So it's the clinician's decision. Clinician will actually try and feel the anterior vaginal wall and try to assess if the bladder can be involved. If the bladder is suspected to be involved, it is good to do a cystoscopy because it changes the stage and of course in future treatment as well.
Thank you, sir. Routinely we do cystoscopy or examination of under anesthesia.
Sir,
No, we don't at our center.
Yeah. Okay, you have already answered. What is your institutional protocol first?
So actually, Supriya was one of the pioneers in writing up this National Cancer Grid Protocol that we follow. And that National Cancer Grid Protocol has a fantastic way of presenting that depending on your resources, you use your protocol. So because we have all the resources in the tertiary center, at our center, we will do, of course, we do a clinical examination of the patient, and then it will be followed by an MRI scan of the pelvis, and then CT scan of the upper abdomen and the thorax to stage the disease. And then depending on what we, of the stage, if we suspect involvement of the rectum, sigmoidoscopy is necessary. If we suspect involvement of the bladder, cystoscopy will be necessary. So that is what we do. But in resource-constrained places, a CT scan of the abdomen and pelvis, chest X-ray, or sometimes ultrasound evaluation of the upper abdomen is also good enough. So depends on the resources, depending on the availability of the resources and expertise, the protocol will vary.
So one message, in which stage do you go for the CT cyst in carcinoma cervix? Every cases you go for the CT chest?
Go for what, sorry?
Chest CT, sir.
Yes, it is not essential. It is not essential, but there are two reasons. Of course, you can occasionally get a distant metastasis, and we have picked up at least 5 or 6 cases of second primary lung cancer in women with cervical cancer. Sometimes the etiology is the same. So our chest CT has actually helped us in that way.
Sir, if we stage 2B and onwards, then we advise the patient for chest CT. Sometimes we have seen that it is stage 2B or 3B, and when we did
it's perfectly acceptable to do a simple chest X-ray, depending on the resources. But as I said, we are a tertiary center. We have the resources. We have the ability to do it. So that's why we do it as a protocol. But this is not a universal rule. I would recommend that you all read Supriya's the National Cancer Gate Protocol. It was very nicely written, very nicely laid out what should be done in different resource constant places. So yes.
Dr. Bhavana, please. Bhavana?
Yes.
Yes. In your center, if it is cervix stage 2B patients and refer to you, then do you go for chest CT or directly you go for chemoradiation? Yeah.
No, we are following CT chest, abdomen, and pelvis for all patients. Actually, we are lucky because at an institute, we've asked the CT chest, abdomen, pelvis to be charged in the same rates as CT abdomen and pelvis for cancer patients. So that has helped us. So the standard is CT chest, abdomen, and pelvis. But like Dr. Pamik said, again, you can go in for a CT abdomen and pelvis, and you can do an X-ray chest also. But if you have the facility and if finances are not an issue, then it is always better to have a complete CT scan.
So I want to add here that in our country, most of the situation is out of the pocket. So my take is that, well, we can say that X-ray is doable, but there is a opportunity of doing a CT scan. We should give it to the option of the patient that this may give you some additional benefit and let the patient to decide. Because so if I decide it is the resource constraint and I do X-ray chest, so it is I'm taking the responsibility of the patient that we should not do. When it is an institution, that is an institution take its decision. But when it's out of the pocket, personally, what I believe that we should give that it is a stage 2B or 3A patient, there is a chance of risk of metastasis, which may not be picked up with X-ray. So ideal situation, CT scan could have been done. Well, if you agree to spend that much of money, you can go for it. Otherwise, the problem is once we said X-ray is okay, so somebody can take a message that, well, we don't need a CT scan. So there is no need. It is better preferred, but if not possible, at least the X-ray test. That is the message. So we should not avoid, as Dr. Jaydeep was initially telling, when it is a 2A or 2B or advanced, there is always, there is a rationale of doing a CT scan chest if there is no issue of fund is coming. But when the out of the pocket, we experience that we cannot assess the ability of the patient. When we tell them, sometimes they come out with the proposal, well, they want to do it. So it is their life, they should take the decision, not us. We should not dictate that no need a CT scan chest because it is not 1A, it is 2B. So there is a fair chance that there could be something which may not be picked by a X-ray chest. Thank you.
Kamal Bhai, this is Janatul. Can I add one sentence regarding
Yes,
this?
please.
Actually, I think when the vagina is involved, then we can suggest to do CT chest because vagina is rich in blood supply and every possibility of involvement hematogenous spread to the lungs. When the vagina is involved, like stage 2A, 3A, we should suggest to do a CT chest.
Thanks.
Thank you.
So, can we proceed?
Yes. Next. Mahabuba, next. Mahabuba?
ম্যাডাম ওরা রেগুলেট করছে একটু দেখে দিন
Samir, next slide.
Samir, next. Yeah.
Cystoscopy showed normal bladder mucosa.
They did cystoscopy. You did cystoscopy, yeah?
Yeah, it is possible in our situation.
Next.
What is the preferred imaginary modality? Ultrasonography, CT scan, or MRI?
In case of carcinoma cervix?
in case of carcinoma cervix. We have
CT or
already
MRI?
CT, MRI.
Again, as I said before, it all depends on the resources available to you.
Yeah.
A perfectly acceptable imaging modality is CT, thorax, abdomen, and pelvis. If I'm thinking of doing radiotherapy only, but if I'm contemplating surgery, then an MRI scan will help us to determine two things. First of all, whether the parametrium is involved, that's important. But also, as I said before, we avoid dual treatment. So we also try and assess the invasion of the cervical stroma by the tumor. If we find that the significant amount of cervical stroma is involved, then it is highly likely that even after doing the surgery, the woman will need a radiation therapy. So we avoid doing that and send the patient to our radiation oncology colleagues. So that's how the MRI, especially in early stages, help us to determine whether we're going to take the patient up for surgery or not. MRI of the pelvis is good enough.
Yes, sir.
Next. Preferred option in low resource setting. Sir, what is the preferred option in low resource setting?
So, I mean, there was a long history of struggle to introduce imaging as a part of the staging process in cervical cancer. It had been resisted till 2018, when finally the FIGO agreed that imaging is necessary for staging the disease. Because previously it was just clinical examination, a chest X-ray, if required a UA or cystoscopy. But now, of course, imaging is available in most of the places. There should be at least a chest X-ray, an ultrasound examination of the rest of the abdomen, and a CT scan of the pelvis or an MRI scan. That is a bare minimum requirement.
Thank you, sir. Next slide, please. MRI of lower abdomen done by this patient, and MRI was suggestive of locally advanced cervical growth protruding into the upper vaginal canal with parametrium and posterior wall of bladder involvement. And the TNM stage was T4A N0 M0. Can we go for both CT scan and MRI for this patient?
Next, you did those. Yeah.
CT scan of whole abdomen was done that revealed locally advanced cervical cancer, cervical growth confined to the pelvis with bladder base and vaginal invasion without vesico-uterine junction or ureteric junction involvement. And the staging, TNM staging is same as MRI.
Why did you do dual imaging to these patients? Both CT and MRI?
Second, CT, first we done MRI and second stage CT to see further involvement.
Yeah, CT scan of the upper abdomen would be good enough, and the chest. Pelvis is just a repeat examination of the same thing. MRI is more precise if I'm thinking in terms of bladder involvement there or not. But of course, on the image, you can only suspect, you cannot confirm. So a cystoscopy is essential. If you suspect bladder involvement, you will have to do a cystoscopy to exclude bladder involvement, because that will change the stage of disease.
Thank you, sir. What will be the final staging according to FIGO 2018?
Next.
The image was too small to detect any nodes. So if the nodes were suspicious or positive on MRI scan or CT scan, then of course staging will be different from what we see here. It can be 4A based on the imaging, but if you suspect a 4A, you have to do a cystoscopy.
Cystoscopy, this will be done, and it was normal. Cystoscopy.
Normal. So it's not a 4A disease. It's a stage 3B or 3C disease, depending on what we see on the about the nodes. So the assessment of nodes are very important on the scans.
Bhavna? Dr. Bhavna?
Yes.
Yeah. So what should be a treatment plan in this patient?
So she's a candidate for concurrent chemoradiation. So she should go in for concurrent CTRT, followed by assessment for brachytherapy.
During the same time, CTRT, brachytherapy in the same time?
No, followed by brachytherapy.
After completion of chemoradiation, then brachytherapy?
Yes.
Next. No,
can we go for surgery?
No.
No.
Absolutely no.
Yes,
Radiotherapy?
Yes, chemoradiation. Yeah.
Definitely.
Definitely. Right.
So Joydeep, I need a comment for the last one, NACT followed by surgery.
No. Again, absolutely no. Supriya will. There's a very long, fantastic study from TMH Mumbai, and we were all hoping that yes, this will be a positive result, but unfortunately, neoadjuvant chemotherapy followed by surgery is not an option. We are just allowing the disease to grow, and the prognosis is worse.
If parametrium free, then radical hysterectomy? No. Yes, sir?
Yeah, parameter is not the only criteria to decide for hysterectomy or not. So, as I said, we have to avoid dual treatment. We try and avoid dual treatment. And to avoid dual treatment, we have to, first of all, the size of the tumor. More than 4 centimeters is very likely that the patient will need radiotherapy. If the tumor is invading more than 50% of the cervix on stromal involvement, then of course, there's a very high chance that patient will need radiation. So why subject the one with double complication? Just go for chemoradiation, which is cure intent, and the patient will have very good result. Just because I can operate, I will not operate on every patient.
Bhavna?
Yes, I'm very clear it has to be radiotherapy, and I agree with Dr. Joydeep. Plus, I think getting a negative vaginal resection margin will also be difficult, just adding on to another point.
Yes. Next. So anybody can ask any question about this. There is both faculties are with us, so anybody can ask. If you have any question in your mind, you can ask to our faculties, please. Everybody are requested.
Shana, yes.
Yes.
I'm Dr. Karun Nahar. I want to say one question or proposal. As because the treatment modalities is unique for all the patients, but the situation practically, the patient economical status, situation facilities, institutional facilities, and of course the specialist, especially the radio-oncologist or oncosurgeon, it is not available throughout the country. So the treatment must be unified and unique. So for this purposes, we can take some decision through this webinar. As a globalization, we can unite together for all the other countries, different countries. So we can take some proposal and decision and do variation, some little bits from the treatment in center to center. Is there any facilities? Is there any comment regarding this?
Sir, have you any comment?
I just opened my heart when I mentioned about training. It is essential that there is a dedicated training program in the country, dedicated training program for not only just a surgeon, a gynecologist. You have to have a pathologist, you have to have radiation oncologist, you have to have a medical oncologist, intensive care backup. So it's a total package of care for cancer patients, and that's a training is essential for every person to get best result. Yeah.
So, Professor Joydeep, sir, I would
This
like
one
to
is
ask you
very
two questions, simple questions.
sure.
Sir, in this particular case, cystoscope was normal. And what should be the, if we see that there is no lymph node involvement, what should be the figure staging? And if we see lymph node involvement, that it will turn to stage 3C, that's all. But if there is no lymph node involvement, our cystoscopy is also normal. There is no hydroneutral or hydronephrosis, blood well also normal. So that what should be the figure staging in this particular case?
What I could see in the image, parametrium was actually involved.
Yes, involved.
So it's case stage 2B in that case.
Stage 2B. Okay,
Stage
sir.
2B, yeah. And if, of course, in stage 2B, almost a fourth of the cases will have nodal involvement. So nodes should be examined very, very carefully.
Sir, for the nodal survey, what should be the ideal investigation?
MRI is very good at it. They can actually do diffusion weighted image. Diffusion weighted image actually looks at the movement of the water molecules in the tumor cell and the non-tumor cells, and an expert can actually differentiate between an involved node or just an inflamed node. That is more possibility of MRI. Good experts on CT scan can also say that, but CT scan relies on the size of the tumor and sometimes the shape. But again, if you have a suspicion, I would rather call it a nodal involvement, and during radiotherapy, those areas are additionally treated. Boost radiation can be given to those areas.
So another question.
Sir, I have a question, sir. If there any, is there any method for sentinel lymph node detection, sir?
Sentinel lymph node detection is a routine thing that we do for endometrial cancer. Unfortunately, we will probably operate on. We operate at least 1,000 cases every year, and the number of patients having operation for cervical cancer maybe 5 a year, because almost everybody is so advanced that they go for radiation. So it is routinely being done. We do sentinel node, but it is still in a learning phase. So even if we do a sentinel node, we still do total lymph node dissection. Maybe in 2-3 years for endometrial cancer, we will not do complete pelvic node dissection. We will just.
Sir, in cervical cancer, before treating cervical cancer, before surgical treatment, is there any routine workup for sentinel lymph node detection?
What we do, I think it's the same practice in TMH Mumbai as well. That before we touch the uterus, we do the lymph node dissection and send it for frozen section. Because if the lymph nodes are positive, we stop. We don't operate anymore. Because if the lymph node is positive, then the woman will anyway need radiotherapy. So we abandon the procedure if the nodes are positive. So we always do the nodes before, send them for sentinel lymph node, not sentinel, frozen section biopsy. If the frozen section biopsy is negative, then only we proceed to do a radical hysterectomy.
Okay, sir. Thank you, sir.
Sir, sir, I would like to ask you another question. In revised figure staging 2018, if a patient in stage 1, if the lymph node is positive, then we should consider it as a case of stage 3C. Yes. Sir, if the lymph node is positive in case of stage 1, then what is your option or treatment modality for this particular type of patient?
Chemoradiation. If the lymph node is involved, yes, she will need chemoradiation.
It's just 3C.
Just do not waste your time in doing surgery, because the chemoradiation will be delayed for several weeks. That's not necessary. Send for chemoradiation.
I have another query for clarification. So if a patient comes to us at stage B3, what is your practice at your institute?
1B3.
Yes, sir.
1B3 is a squamous carcinoma. They will go for chemoradiation straight away. With adenocarcinoma, there are some discussion that they may not be as radiosensitive, and there could be a role of surgery in those particular patients. But the opinion is divided. Again, the policy is, even if I'm trying to do, especially a very young woman in whom adenocarcinoma is more common, if I'm specifically trying to preserve the ovarian function, then there may be some justification. So it will have to be a case-to-case basis discussion that dual treatment may still be necessary in those women.
Sir, if a case come to us, if we go for fertility sparing surgery in a case of stage 1B1 and we do bone biopsy, if the result shows margin positive, then what should be our approach?
1B1, you have to go for radical hysterectomy.
No, sir, for fertility sparing surgery, that is cone biopsy,
Yeah, you can.
conization, and if the histopathological report later on shows that margins are positive, then how to proceed with this case?
If you are trained to do a trachelectomy, radical trachelectomy, that should be done.
Okay, sir. Thank you, sir.
These are the two.
These are my queries. Thank you so much.
Most welcome.
Dr. Joydeep, I think as you mentioned that as per your protocol, institution protocol, and also the TMH that you do the frozen fast, I think the last week paper came out very, definite paper that there is no, it is detrimental to do surgery with a node positive. This ESMO publication, this came out the last week. And that have resolved, there was some believer that taking out nodes could be helpful for chemoradiation, which is not true at all, because we people do some boost on the positive nodes so that we take care. So, I think that is the paper that has really given a fantastic conclusion, as you people are already practicing in favor of that to abandon the surgery the moment you find that there is a positive node, even a single one. True.
Yes.
If there is not positive, there is no survival benefit. That paper published just few days ago. Yeah.
Okay, there is another point that I would want to make, especially for the radiation oncologists present here, that when you are staging cervical cancer, please stage the local and the imaging separately. So suppose it's a 2B clinically, and then it's a 3C, stage it separately because it's going to have implications on your the brachytherapy part also. So the bulk of the tumor, what I mean to say is the bulk of the tumor also needs to be ascertained separately, along with the FIGO 18 staging. So do the imaging part, stage the imaging with the nodal, that is, it could be a 2B with a 3C1 or a 3C2. So that needs to be done.
So I think what Bhavna is trying to tell to our resident, that once we get a referral from Dr. Joydeep, that what he is writing is a clinical staging. For example, it is 2B. Yes. The moment we are going for a practically doing, say in our context, it is not an immediate referral. Say he has done it 1 month back. By this 1 month time, maybe the disease has progressed, or it was clinical staging, not adequate imaging was done at some periphery center. So whenever we are going for radiation therapy, chemoradiotherapy, as we are telling in cervical cancer, there is only one chance and one modality. So we should do adequate imaging to get the maximum information so that we really know the bulk of disease, like the tumor size, extension, and also the node. Say, for example, in node, we are talking about the pelvic. So why we are always talking about this CT scan? Sometimes we do miss the paraortic node because we don't know that maybe there one paraortic node is enlarged. If we don't do a CT abdomen, we may miss it. Only pelvis, we don't see it. So that may change the whole scenario. Our total radiotherapy planning is changed. So for the oncologists, radiation oncologists, especially for planning the field and also brachytherapy, we must know that what is the real scenario of the disease. And it is not to be blamed to our colleague. Sometimes they have not done all the imaging, or it was referred maybe 1.5 months back. So in our practice, sometimes we keep on chasing the same staging, something written on a piece of paper, and plan on that. And as you know, in a busy clinic, maybe we missed that already had progressed to maybe some stage higher. So as Bhavna was telling, if we know it properly, we can really treat it nice. And cervical cancer is one of the miracle that where we get a 60 to 70% survival, even in stage 3, if we can really properly treat it. So we should not miss the chance. And for our colleagues or non-oncology colleagues, that to treat cervical cancer, we don't need rocket science. Even with the cobalt and a good brachytherapy in a periphery center, we can really do a good job. If somebody thinks that we need IMRT, we need linear accelerator, many fancy things, it is not always true. There are many examples that with cobalt 4-field box technique and proper planning with ICRT, their good result is possible. Bhavna, I need a comment from you here.
No, I especially endorse that. And it is important to do a good radiation and brachytherapy. And not only in Bangladesh, I would say even in centers like ours, I'm also sitting in a tertiary institute, we do face these issues. Incomplete surgeries, lack of availability of the desired technology. That may be a problem with us also. So your basic treatment should aim at good chemoradiation followed by brachytherapy within the stipulated time period of 7 to 8 weeks. So that is the take-home message for locally advanced cervical cancer treatment.
So what is important here? The staging is very much important. Proper staging. Am I correct?
Yes, proper staging is important. And at the same time, the tumor size, again, is a very important prognostic factor.
Yes, sometimes we think that the patient is very poor, that if we are in a periphery or in a center where the patient that she is very poor, so she can do either CT scan or MRI, so it is advanced stage disease, either stage 2B or 3C or 3B. Why should we advise the patient for either CT or MRI? So yeah, as it is confirmed that it is 3B, so we refer the patient to radiation oncologist for chemoradiation. Sometimes we think so. But in such a time or after completion of treatment, the patient, they come back to us with the residual disease or either recurrence. In that time, then even the patients, they are ready to sell their either their land property or everything. So I think we should not do that in every case in advanced stage or in stage 2A, 2A2 or either in big tumor. We must have to go for this advanced imaging. Am I correct, Dr. Bhavna?
Yes, a CT scan, a minimum of CT scan of the abdomen and pelvis should be done.
Okay. Yes, sometimes we think that it is very poor, so why should we go for this? So one thing is that I think Dr. Kamal Bhai, he will be also agree with me that we must at primary time, we must advise the patients the all type of imaging that is available in our setting or the patient can, because first time if we stage the patient properly and then if she get the proper treatment, then I think outcome will be better.
My answer is more simple. It is the patient to decide.
Yes.
It is her life or his life, and we should give them the option that this is the best thing. And we should not give a verdict to them. Sometimes as a doctor, we make a mistake. We give a verdict, we take their decision. They are not able. We should say that this is the...
But we must have to counsel them.
We must counsel the patient.
Yes. I think if we counsel properly, then the patient...
If they say they cannot, well, we put a note.
Yes. No. We think sometimes we don't counsel the patient. If we ask them, then I am poor, how can I do this? But if we properly counsel them and properly they explain everything, then I think the patient may agree.
The other thing I would want to add is like we also have patients who come from really poor socioeconomic background.
Yes.
So one way of thinking is we also see whether this patient is for curative treatment or not. If this patient has a heart fixed growth and it's going up to there's lower vaginal extension, I know I'm not going to be able to do a brachytherapy. So I will not insist on a CT scan in this patient if she cannot afford. Because if I cannot achieve local control, I would not attempt to control the para-aortic lymph nodes if they are present in that case. So, these are the kind of situations where we bargain or we decide from case to case whether we need to do all the investigations or not. But if I feel this patient definitely local control can be achieved, I would counsel the patient such that she goes in for a CT scan, because I think in the long run that is not going to be cost ineffective. It is going to be a cost effective modality where we are trying to give the patient a good treatment rather than missing out on some important factors.
Shahna, তাহলে ফার্স্ট কেসটা কি ডায়াগনোসিস cervical cancer or cancer, dual
cancer.
So is there any role of ERPR in this case? Question to Jaydeep or Bhavna.
That's what I mentioned at the very beginning, that she needs immunohistochemistry for the diagnosis, not just ERPR. You need to have a full battery of immunohistochemistry to differentiate between a endometrial and a cervical cancer.
So Dr. Jaydeep, would you please shed on light something that sometimes say, as you said, that you need to do the full panel of IHC. That is very important thing, because sometimes say I have in my mind that ERPR will be positive, here it will be negative. So one IHC panel, message is not enough to make a conclusion. That is the message here. what Dr. Joydeep is nodding his head, that either presence of ERPR or absence of ERPR is suggestive, is not a conclusive thing. And IHC is never a conclusive. It is a full panel with the histopathology information all together come to a conclusion. It helps. And one information is not enough, Joydeep.
So yes, background is the morphology. So the histopathologist, the oncopathologist will actually look at morphology first and then try and fit. So many tumors are positive for 3 of those panels and negative for 2 panels. And then there will be other tumors which will be positive for another 2. So it's a match and it's a very complex thing that the pathologist should have expertise in and identify the disease origin by a match of different types of combination. See, as Professor Goodman was saying about the HPV test can be positive in about 20% of the cases of the population. So just presence, the absence of HPV may sometimes indicate it's an endometrial cancer, but the presence does not prove that it is a cervical cancer. So it will have to take the thing into context and then decide which is the correct one. So it is not just one ISC and I know the answer. It's not like that. It's a panel and a lot of expertise and so you put the image, you put the clinical presentation and the ISC together to come to a conclusion diagnosis.
Yes. And even one more thing
Dr. Anisha.
Yeah.
Yeah, I want to just tell you one thing about immunohistochemistry. That is, ERPR is a part of immunohistochemistry, and when we have to need to differentiate between cervical or endometrial cancer, then usually 4 immunohistochemistry suggested: ERPR, P16, and vimentin. In case of endometrial cancer, vimentin is positive, but in cervical cancer, vimentin is negative. P16 usually positive in cervical cancer, and P16 negative in endometrial cancer. And ERPR usually it may positive endometrial cancer also in cervical cancer. So as Dr. Kamal has suggested that the full IHC, that is immunohistochemistry panel, should be suggested to differentiate between cervical and endometrial cancer.
Yes, thank you.
But again, one more thing that I would like to add here is that despite an IHC, sometimes it may still be difficult to differentiate between endocervical adenocarcinomas and endometrial cancers, because P16 may be positive also in some endometrial cancers too. And so that is a situation, I mean, we do encounter occasionally. I had a question. Suppose we were not able to prove on IHC that this patient, the previous patient that we discussed, was a CA endometrium.
Yes.
Then would our approach would have been different?
Yeah, then we go, of course, then it's a multidisciplinary approach we take, and we take a final call. What would be our final decision in the team that, as for example, in the first case, based on the image, based on the presentation, and if the immunohistochemistry was inconclusive, I would have gone for an endometrial cancer. I mean, I could be wrong, but we have to take a decision.
Yes.
It is the MDT. So the MDT will take the responsibility. No single person will take that responsibility.
Yes.
That's true. Okay, Shana, I think we can ask the chairperson to make a comment.
Shana,
yes.
I want to listen.
Just a minute. Yeah, I request the chairperson to give her comment.
I want to listen from Dr. Sabia and Dr. Mahbuba.
Yes.
Those who have presented the cases.
Sir.
How much they learned from this.
What is their message they have taken? Both the presenters. Sir want to know from both the presenters.
Yeah, Sabia Mahbuba.
Sabia, are you here?
Thank you, sir. It is new for us. This oncology club is very much informative to our new gynecologist, and who I am really interested to go into gyno-oncologist surgery, and in future we will hope that our training and
panelists from our home teachers. Our training will be very much needful to us. So thank you all Oncology Club and my department to give the opportunity to present this case, and I learned from this session in March. Thank you, sir.
Thank you very much.
Mahbuba.
Request in future also will get you.
Congratulations, sir. You see, it is a new event for us in the COVID period because we are extremely now homebounded. We can go anywhere for any training or further evaluation of the patient also. So, sir, I want to recently in Rangpur Medical College there is a new institute of cancer institute begun to establish. The government has taken the protocol. We need some training, extensive training for establishment of new research institute. So we advise, please give some opportunity for training in oncology for better surgeon, better oncologist, and better pathologist. Thank you, sir.
Good, very good. We need more gynecologists, gyne-oncologists. It's a big problem. However, I'm very happy that you are getting oncology. Thank you very much. Now, Sahana, finish it.
Yes, sir. Thank you, sir.
Chairperson, please ask the chairperson to make the comment.
Now I will request our to the chairperson, Dr. Professor Kamrun Nahar Jui, please give your comment and then take. Yeah.
Okay, thank you, madam, and distinguished panelists and other professors and home and abroad who are very much learned and give us a vivid and very much explanatory discussion to this session. And of course, sir, it's a very valuable session for all of the audience who are participating in this seminar or webinar. And with the advent of COVID, the globalization is very much easy, and we can very much uh, can meet together with the advent of the virtual meeting. So I am very grateful and honored to this tumor board discussion and Professor Shahana and other abroad participant and expert panelists. They discuss all the things very explanatory and specifically, and a small discussion is very much helpful. It is needless to say that everything, the medical science is ever changing day to day, and treatment modalities and all the facilities of investigation, every time it is changing. And treatment, of course, it is distinguished and specific for all the patient, irrespective of our economical status or country status or any other situation. But it is true that it is not feasible for all the centers and all the countries in every times. But we want to unified a decision regarding the treatment protocol, which is feasible, which is all the patient cannot take the better treatment. It is truth, but we are trying every time. The physicians, we are trying to give the better services and the better treatment for the patient. And if it is very much essential, and we can feel every of us that it is necessary to train some persons or physicians that they can decide which patient and how we can serve them, because we know the cancer is very much increasing in incidence all throughout the world. So it is of course very much time demanding the persons who can serve the cancer patient. And for the expert panelist and distinguished guest from the home and abroad, I am giving very much thanks to all of them, and I hope we will unite further in near future in another issue And good of luck. Thank you, and thank you very much. Good night.
Thank you, Appa. Thank you very much. It is now too late, so I am very much grateful to our expert panelists and our foreign faculties that you have given around 2 hours time for us and for our doctors, and I think that in future you will be with us, and we request you and we get your response. And I am very much grateful to you all and our oncology club, sir. This is our oncology club for you. As regularly Dr. Bhavna, she joins with us and she gives us this opportunity for this discussion. And I request you, sir, in future I will request and also invite you for this type of session. Usually in weekly, due to this COVID situation, weekly we are arranging the tumor board, alternate week tumor board and alternate week journal club and the debate session. And thank you, sir, and thank you, Dr. Bhavna, and all the participants who are with us, because in absence of the participants, this webinar is not possible. So I am very much grateful, and Oncology Club is very much grateful to you all. And thank you very much. Thank you.
Thank you.
Thank you, Oncology Club. Thank you, foreign faculties. Thank you, hi, sir, and everyone. Thank you so much.
Okay,
We are
bye-bye.
very
Allah
much
Hafiz.
grateful.
Bye-bye. Allah Hafiz,
Thank you,
everybody.
sir. Assalamu alaikum, sir.
Wa
Goodbye,
alaikum
sir.
assalam wa rahmatullah.
Thank you, sir. Thank you for giving the opportunity to Rampur Medical College, sir. We are blessed. Thank you, sir.
In future, again,
We want everybody
Okay,
with us.
inshallah.
We
Thank
want
you, sir.
everybody with us. We are open.
Thanks, sir. Thanks for the great initiative. Thank you, sir. Assalamu alaikum.
Wa alaikum assalam wa rahmatullah. Okay, bye-bye. Allah Hafiz.
Allah Hafiz.
End the
Kamal bhai,
session.
Shanapa, thank you. Allah Hafiz.
Thank you, Sanapa.
Assalamu alaikum.
Should I end the session?
Yes.